My name is Fiona from Alfred Health Radiation Oncology in Melbourne, Australia. And I'll be talking to you today about whether a patient's external surface can be used as an acceptable surrogate when monitoring intrafraction internal tumour motion during stereotactic ablative radiotherapy or SABR treatment. In full disclosure, Alfred Health Radiation Oncology is a reference site for Vision RT in Australia. So this presentation will cover a brief introduction into SABR and SGRT at Alfred Health, before explaining why we decided to undertake this study, how we went about it, what we found and what we've taken away from it. So just a brief introduction into SABR. So SABR delivers high doses of radiation to usually small tumours with rapid dose fall-off, requiring treatments to be really accurate. To help maintain accuracy, multiple cone beam CTs are often required, making these treatment times very long. Along with multiple cone beam CTs, motion management systems such as an SGRT system can help with maintaining positional accuracy. As we all know, SGRT uses 3D cameras to track a patient's skin surface, providing us with translational and rotational information that not only helps us during the setup of the patient, but also monitoring the patients during treatment. So let me give you a little bit of history about Alfred Health Radiation Oncology. We were first established in 1992 as a 2-LINAC department and quickly grew to 4 at our Melbourne site. We also have a rural site that has got 3 LINACs, and across the 2 sites we've got 3 true beams and 3 21IXs. We eliminated tattoos first on breast patients in 1998, then in later years on all our treatment sites. We first used SGRT on our patients in 2009 in conjunction with skin marks, so tattoos as well as permanent marker lines. Then in 2011 we treated our first SABR patient, and in 2013 we've treated our first SABR patient using SGRT, mainly for monitoring to begin with and then in later dates for setting up as well. And as a side note, we had our first markerless SGRT patient in 2017 and are now a completely markerless department. So at Alfred Health, we use Align RT and Gate RT, as our SGRT systems. All of our SABR patients have a 4D CT, are planned in Eclipse and treated on our TrueBeam LINAC. All of our SABR patients are set up using SGRT alone, so no body marks. And we take a cone beam CT to check their setup, make any of our initial corrections. Then a new gated SGRT reference image is taken. And then this is to zero our position to tell so that we can tell if the patient's position has changed from this point. Then a repeat cone beam CT is taken every 10 minutes before any of our non-coplanar fields, or if the SGRT system indicates that the patient's position has changed. Our tolerance for re-cone beaming these patients is 2 mils and 2 degrees. So why did we decide to undertake this study? So after treating multiple chest SABR patients, the staff started to question, why do we need to keep taking these cone beam CTs when we can tell from the SGRT monitoring that the patients hadn't moved, and that the corrections that we were having to do after the repeat cone beam CTs were minimal. We were also noticing that most of the patients' appointment times were spent taking and assessing the cone beam CTs, and started to wonder if these repeat cone beam CTs could be eliminated. So then the questions were brought forward. Could we reduce the amount of radiation, unnecessary radiation exposure that these patients were having to receive by reducing the number of cone beam CTs required? And if we didn't have to take so many cone beam CTs, can we reduce the overall amount of time that these patients need to spend on the bed? So to answer these questions, we needed to know, well, what's the tumour doing inside the body during the treatment? We know that SGRT is good for monitoring external surface, but we want to know, what does it mean for the tumour inside the body? Does the tumour move relative to the patient's movements? And if the patient's breathing changes, what does that mean for the tumour motion? So we retrospectively reviewed 20 chest SABR patients who were treated from the 1st of July 2017. We started with our chest SABR patients first, as these patients were more frequent, making it easier to get our data sooner. For patients to be included in this study, they required a minimum of 2 cone beam CTs to be taken for any one appointment.
one at the beginning of this setup, and the second one at least after one of the beams were treated. This could be halfway through their treatment, or for example, after the first beam, if they noticed that the patients had moved. Some patients only had 2 scans taken, some had multiple per appointment. They also required a new gated SGRT reference image to be taken after every online move to zero that monitoring position. Patients who did not have a new reference image taken were excluded from this study. All of our patients have their monitoring data recorded, so it's just a matter of going back and finding the ones that we needed. The monitoring data is recorded as a text file and gives us information such as positional deviation, when fields were gated, and when beam hold was activated, as well as much more. So then what we did, we compared the positional displacement of the tumour as indicated by the cone beam CT to the patient's external surface as indicated by the SGRT system at the time of cone beam acquisition. So, in other words, what we did was take the displacement values from the cone beam CT when matched to the tumour volume itself, then took the displacement values from the SGRT recorded data, but only at the time that the repeat cone beam CTs were taken, so not the first one. And then took an average of these values across that time in each of the directions. So ant post, supinf, left, right, as well as pitch, yaw, roll, and rotation. The hardest part about this step was finding the part of the recorded text file that was relevant, as the recorded file includes all the displacement values and data from that particular appointment. So these are the values that we're wanting to know. So once we had these displacement values, we wanted to look at the difference between these two numbers to see how close they were, giving us a discrepancy between internal tumour position and external surface. This process was applied to all of the sessions to work out an overall average displacement for our chest sabre patients. So from the 20 patients, we ended up with 17 lungs, 2 scapulars and 1 rib, with a total of 65 sessions or cone beam CTs analysed. Of the 20 patients, we had 1 patient who showed a consistent magnitudinal and directional displacement across all their appointments, but even then, none of our patients had a discrepancy greater than 5 mils or 3 degrees for any of their sessions. So after combining the 65 sessions to get an overall displacement, we noted a good correlation between internal tumour motion and external surface of 1 mil and less than 1 degree for these cohort of patients. So in conclusion, for our chest sabre patients, we can happily say that the patient's external surface, as defined by an SGRT system, is a reliable surrogate when monitoring internal tumour motion. So following this study, we can now eliminate that 10-minute cone beam CT and the cone beam before the non-coplanar fields if the SGRT system indicates that the patient's position and breathing pattern has not changed, but from fraction 2 onwards. We have opted to still maintain the part-way scan on fraction 1 to initially determine if there is a correlation between internal and external motion for each individual patient. The decision is then made following this whether the 10-minute scan is still required. The option to still take the 10-minute scan is there should the staff feel that it is necessary for that particular patient or just for that particular appointment. The repeat cone beam CT is still taken if the SGRT system indicates that the patient's position has changed. This has ultimately allowed us to reduce the amount of radiations patient receives from the extra scans and has reduced the time required for these treatments, as we no longer need to take the time to take and assess these cone beam CTs. We've already noticed a reduction of about 10 minutes in most of our chest sabre patients by eliminating this unnecessary scan. So the next step for us is to look now and see if the relationship is the same for abdominal and pelvic patients, in the hope of being able to reduce the number of cone beam CTs these patients require. From the data we've already analysed, these patients appear to have a similar discrepancy, but we cannot confidently say that the correlation is the same yet until we've finalised the study. So stay tuned and hopefully another update in the near future. Thank you.